All right, everybody, we are going to go ahead and get started. We might have a few more people kind of coming in a little bit, and that's okay. But welcome to our second Live Well event of 2026. We have Dr. Lee with us today. We're really excited to hear her speak about botulism toxin, botulinum toxin, not botulism. Sorry about that. Botox. Should have just said the short version of that. But she's going to speak about Botox with us today. And before we start, I am going to have Andy Miller come on up and talk really quick. Private Home Care is where he works, and he's going to just talk a little bit about who they are and what they do. They sponsored this quarter of events for us. And Andy comes in, yes. And Andy comes in and works out with us pretty often too. So you guys might recognize him. I know I had somebody come in and said, "Is that Andy?" I said, "I know him." And I said, "Yeah, he is." So yeah, go ahead and you can have a couple minutes and then we'll let Dr. get started.
Okay. All right. Blake, thanks for the intro. Yeah, I'm excited to be here. Again, I'm Andy Miller. I work for a company called Private Home Care. Super excited to sponsor this event. We offer caregiving service. Basically, we add an extra layer of support for people who just want to stay independent wherever home is. It can be in a private residence. It can be in a living community. It can be wherever. So we help out with things like overall safety, oversight, and supervision. We can help with toileting, with bathing, transfers, medication reminders, transportation, driving to and from appointments, things like that. So it's super customizable. There's a lot of other fun things that we can do that I can talk to you more about if you're interested in that. But we do offer all the way to around the clock care 24/7. And then we do live-in care as well, where a caregiver, if it makes sense and if it's something you're interested in, it's a really cool idea where a caregiver can actually live in the home with someone for however allotment of time that someone would need. So really cool. We're in both the Missouri and the Kansas sides, so provide care on both sides of the state line. I'm actually a physical therapist by trade. Currently, I'm not practicing as a PT, but events like this, and obviously my role as in home care, really helps me to kind of stay current with some of the needs in the home and help people just in a different way. So definitely an honor to be up here and support this great organization. Like she said, I do recognize it. A lot of you from strength classes. I usually try to come at least once a month just to get my PT fill and to feel like I'm helping someone on the exercise side of things. So anyway, super excited to be here. Our table is right over here. If you guys ever have questions, just want to talk a little more about how we might be a resource for you or someone you know, I'm more than happy to talk through it. We're a family-owned business and located about 5 to 10 minutes from here at 435 in Metcalf as our location. So definitely appreciate the opportunity. And if you ever want to talk more, feel free to bounce on over and happy to talk with you a little. So thank you, and thanks, Dr. Lee, for being here too.
Great. So good afternoon. I'm Dr. Andrea Lee. I'm one of the neurologists, wound disorders, fellowship trained neurologists at KU. Just on a personal note, in case you were wondering, yes, I am pregnant. Yes, I'm due in October, and I have a 4-year-old son. This is a girl, so we're excited. Thank you. So I'm going to be talking about botulinum toxin, its use in Parkinson's disease. So botulinum toxin is a highly potent neurotoxin that is produced by the bacterium Clostridium botulinum. And it becomes pathologic if you ingest it through food, because the toxin can grow in improperly processed or canned foods that have low acid, low oxygen states. And so if you see a canned food that is bulging and then it's foul smelling after you open it, then you do not want to eat that, because it probably has the Clostridium botulinum in it. And then when we talk about infant botulism, that's when little babies, infants below the age of 1 year old, if they eat honey that is raw or has the spores, the botulinum toxin spores in it, they can become very flaccid and paralyzed and even stop breathing. So pediatricians say never to give honey to a baby under 1 year old.
Mm-hmm. I've heard that.
Yeah. But in medical use and cosmetic use, it was found that when you purify this toxin, you can use it for various applications. So what it does is it blocks nerve signals and causes temporary muscle paralysis. In 1973, the history is actually really interesting. In 1973, there was this ophthalmologist, Dr. Alan Scott, who used the purified version of the toxin in monkey experiments. And then he was doing experiments in monkeys' eyes to treat the indication of strabismus. Strabismus being kind of like lazy eye, or when one eye is a little bit overactive and they just don't track along well. So that was in 1980 and then the first time in 1980 is when humans got to have the first botulinum toxin to treat their strabismus. So then in 1989 is when the Botox, the brand, was created, and the FDA approval was given for the treatment of strabismus. That was the very first use in 1989.
Wow.
And then afterwards, in terms of medical uses, we have cervical dystonia, which is what I'll get into, hyperhidrosis, which is when there's excessive sweating in the armpits or the hands. And then for chronic migraine, bladder issues like overactive bladder, the urologist likes to use that. For spasticity, which is, it could be post-stroke spasticity or spasticity due to cerebral palsy, and dystonia. And then also for drooling, it came out FDA approved later. And then for cosmetics use, about 50% of Botox is used cosmetically, and the other 50% is used for medical reasons. So for cosmetic use, dermatologists like to use it for, the facial muscles, for the glabellar lines, which are also known as the 11 lines, for the crow's feet, and then for forehead wrinkles. So how it works is, let me see if I have my pointer here. I do not. Let me just turn it on to orient you. So it works on neuromuscular junction. So this is a picture of how the nerve interacts with the muscle. And then this is a blown up picture. So usually in a normal physiological state, when the nerve activates, it has to, inside of these vesicles, there is a compound called acetylcholine, which is a neurotransmitter. And then so this vesicle needs to form a complex with this SNER protein. And then it can dock into the membrane of the cell and then exocytose the acetylcholine across the synaptic cleft from the neuron to the muscle cell. And then the acetylcholine is received by the receptors of the muscle cell, and that tells the muscle to contract. So that's the normal state of how muscles contract because of nerve to muscle interaction. But if you give somebody botulinum toxin into their muscles, then what happens is that toxin cleaves the SNER complex, and therefore the vesicles cannot join up with the SNER complex in order to fuse with the membrane, and then therefore the acetylcholine doesn't cross the membrane and the synaptic cleft and cause muscle contraction. So that's why botulinum toxin, it weakens, it paralyzes overactive muscles. There are actually 4 brands of botulinum toxin. Botox is the most well-known, just because it's easy to say and it's been around for the longest. So Botox is onobotulinum toxin A, but we have Xeomin, which is Inco, and then we have Dysport, which is avobotulinum toxin A, and then there's Myoblock as well, ribebotulinum toxin B. And we use it based on our training. So, if we went through fellowship and our mentors were really using only Botox, and that's kind of what we end up doing. Or we use it depending on what insurance dictates. So Medicare lately It's actually not FDA approved. Botox is not FDA approved for using in drooling. So Medicare hasn't saying, oh, then you can only use Xeomin or Myoblock to treat the drooling. So then we have to change things around that. But otherwise, they're interchangeable. There is no difference in outcomes between the different brands. So typically, I tell patients when we get started with the Botox the first time, I tell them it kicks in within 3 days, after 3 to 5 days after the injection. The optimal result will appear around the 2 week to the 4 week, 2 month mark, and then it starts to wear off by month 3. But that's how often the insurance will also happen to cover it, every 3 months. So because we are weakening muscles, that is one of the side effects. It can cause overweakness of muscles. And because you're injecting certain spots, you can have pain or discomfort. So what indications do we use botulinum toxin in? Dystonia is a major one in Parkinson's. So dystonia generally means involuntary muscle activation of a limb or body part that causes abnormal movements, postures, or both. And the movements can be patterned or twisting. Dystonia is very commonly related to off times in Parkinson's when the levodopa, the medication, wears off and you have a low dopamine state in your system. And rarely we do see people have on dystonia where they take their levodopa, but then they get these dystonic posturings, which is different than dyskinesia, which is more of like a wiggling, writhing movement. So the dystonic movements can occur in the face, and that would be called idiopathic orofacial dystonia. People can have like jaw clenching, in which case we inject into their masseter muscles or their temporalis muscles to relax the jaw. People can have eye blinking, excessive eye blinking to the point where they're closing their eyes completely and they cannot see. And that's called blepharospasm. It can happen in the upper or the lower limbs, and it can happen in the neck, which is called cervical dystonia. Most commonly, we see foot dystonia. Foot dystonia can lead to pain and malformation of the toes and the foot and difficulty with walking. We really commonly see the toes are curled down and the foot is turned in. And these dystonic postures can wake one up from sleep, and it can be painful in early morning if your levodopa has worn off through the night before your morning doses do. And then, so in which case we try to cover you with more levodopa for the nighttime. Maybe you have to take a middle of the night dose, or you're taking an extended release at nighttime, or there's Crexon and Rytari, which are the extended release medications. So I'm sure you've seen this before. This just goes to show that every person with Parkinson's is different. This is highlighting that a younger person with mild motor predominant Parkinson's, they can often present first off with dystonia, with the posturing as their first symptom of Parkinson's. And then we have someone with intermediate Parkinson's where they're now on the levodopa for like 3, 5, 7 years, but then they're starting to develop their off time and their on time. And then when they're on time, they're dyskinetic, so they kind of yo-yo throughout the day. And then we have the type of Parkinson's that I guess they're calling it diffuse malignant Parkinson's, but this is basically where it's usually an older person and they don't have a very robust response to levodopa, but it's doing something for them in the background. And because they don't get a really robust response, then they don't have the dyskinesias and they don't have the off time, but it's kind of like a smoldering course. But it's still important to dose 3 times a day at least in these patients. So besides using botulinum toxin injections for dystonia, we can also use oral medications, but this is better for people who are younger, in their like 40s or 50s with Parkinson's and have dystonia, to treat them, because the medications have side effects. So if there's a potential effect to any medication, there's a potential side effect. And the side effects are systemic, which means that it can mess with your entire body and not just focal, which is what Botox can help with, because it's just very focal. Where you put it in is where it treats. So anyway, so the mnemonic for the oral meds for dystonia are ABCD. Artane is the brand name for trihexyphenidyl, which is an anticholinergic. And the The acetylcholine, yeah. So we're actually, so it's because it's an anticholinergic, it means that it's reducing the amount of acetylcholine to lessen that muscle contraction that I told you about with how the nerves and the muscles interact with acetylcholine. Baclofen is used, which is a muscle relaxant. Clonazepam can be used, which is the benzodiazepine. So all of these can have the side effect of drowsiness and just confusion, especially with the artane, which is trihexyphenidyl, that it can cause the anticholinergic side effects, which is dry mouth, dry eyes, constipation, and cognitive issues. So we don't want that, obviously. And then dopamine acting. So A, B, C, D, the D is dopamine. So here again are some common postures that we see for people who have dystonic posturing. So the toes can turn down and the foot can invert, or the big toe can go up, the foot can evert. And then depending on what posture we're seeing, and we examine patients when they're doing all different things, like when they're kind of sitting there or when they're walking, we see how, if the foot swings in or out, to know where we would inject. So these are the FDA approved muscles that we can inject into in the lower limb. Although we sometimes do the other ones, like, yeah, I've done the extensor digitorum longus, even though it's not technically approved, but you have to base it very personalized on what the pattern is in the patient. And then in terms of the upper limb, so most commonly you have a flexion posturing. So the wrist can be flexed and the elbow as well, but you can also have like extensor posturing, or just kind of a combination of also shoulder rotation internally or externally. Honestly, the upper limb posturings are not as common for whatever reason as lower limbs with dystonia in Parkinson's. And in terms of the anatomy of the upper limb, you can inject all these various muscles. Commonly for people who have like their fingers are flexing and their wrist is turned flexing, we inject into the forearm muscles that can help relax those fingers and wrist. There are certain guidance techniques that we use, also again based on training. So if I was trained to use EMG. EMG stands for electromyography. So this is a little machine that you have little leads or like connections here to kind of ground and complete the circuit. And then you have this injection needle, which then when you put it into a person's muscle, you can tell them to like move that certain muscle, and then you'll hear the sound that goes like da, 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 and you could hear the muscle is firing off, and then you know that you're in the right place. And then this needle itself is not just hearing for the muscle, but it also is the needle for injecting the toxin into the muscle. So that's how I was trained to use it, and I use it for cervical dystonia and upper and lower limb dystonia, as well as masseter injections, although the masseter is usually pretty big and bulky and somebody who's grinding a lot, so I don't always have to use it for the masseters, but to give us extra guidance. And then I have some colleagues who use ultrasound. So then they have this little, ultrasound works. You can see the different muscle planes, and then you can see how if there's nerves or vessels in the way as well. I always pull back on my EMG needle, pull back to make sure that I'm not in a vessel, because if I pull back and there is blood coming back out, that means I'm not in muscle, I'm in a vessel, and then I have to reposition myself. And then the other technique is called electrical stimulation. So this is similar. I mean, some of these, actually, this EMG machine, I've used this type before, but it's not just EMG to sense the muscle activity, but it also provides electrical stimulation. So you can press a button when the needle is in the person's muscle, you can press a button and have the machine give some electrical pulses. And then in that case, then you'll see like a particular finger moving and twitch, because it's giving electrical pulses, and then you'll know that you're in that muscle that is causing that twitch. And then when you are happy with that, then you push the toxin in. Okay, so moving on to cervical dystonia. So we said that dystonia is abnormal posturing of a limb or a body part. Cervical is just with the neck muscles. And it can have like overlying spasms that look like it's a tremor, a head tremor. Um, it can be mistaken as a central tremor. This is more so actually for idiopathic cervical dystonia, for people who have cervical dystonia outside of Parkinson's diagnosis. Um, People who have just plain cervical dystonia without Parkinson's, they don't usually progress to Parkinson's. But the other way around, people who have Parkinson's disease and then later on develop cervical dystonia, that's a thing. That can happen. But I tell my like idiopathic cervical dystonia patients, don't worry, you're not gonna likely going to get Parkinson's because it doesn't usually lead to that. But the other way around is different. So there's certain postures that can happen in cervical dystonia. People can have torticollis, which means they're turned, rotated to one side. They can have laterocollis, which means they're tilted to one side. They can have anterocollis, which is when their head is going forward. And that can be a little bit hard to differentiate between a stoop posture. And then they have retrocollis, which is when the head tilts backwards. I'll say that anterocollis is the trickiest posture to treat because the muscles that are pulling the head forward are in this interior compartment of your neck. And that's where your swallowing and your breathing is. And we don't like to go there. So that's very hard to treat. The other postures are easier because they're kind of in the more the back of the neck here and then on the side of the neck. And you're not inclined to hit critical structures. And then I guess this is more for idiopathic cervical dystonia. Patients also often describe something called a sensory trick, also known as a jest antagonist, which is where they have their certain postures happening to them and they do something like just touch their finger on their chin and then it just straightens them out, or maybe their head is like pulling backwards, but then if they put their head against the wall it just really straightens them out. Something about it's not exactly well known why dystonia happens, but there are abnormal circuits that are like a node in the brain that is causing the muscle to fire off. So then we think that if you're doing your sensory trick, that somehow completes a loop where it like realigns the body or something. It's the brain is a strange organ. So just for cervical dystonia treatments, you can try sending people to physical therapy. Obviously, you can do the Botox and then the medications, and then ultimately deep brain stimulation could be a therapy for those types of patients. And then these are the muscles involved. They're all mostly in the back of the neck. And then the sternocleidomastoid, which is this strap muscle over here, can turn the head contralaterally to the other side or can tilt the head to the same side. This is not a Parkinson's patient per se, but it's a regular cervical dystonia patient. And I just want to show you that these are the postures that can happen.
BTX in cervical dystonia. This young man had marked cervical dystonia manifested by retrocollis and torticollis to the left side, dystonic tremor, and marked hypertrophy of the right sternocleidomastoid muscle. He showed marked improvement with BTX injections into the right sternocleidomastoid muscle and both splenius capitis muscles.
That's his before. And I can just fast forward to after. Nice and straight.
Muscles.
So he's good.
How have you been feeling?
But it only lasts 3 months at a time, and then you have to come back and inject. But it's worth it to many people. Moving on to blepharospasm. Blepharospasm is a abnormal contraction of the eyelid muscles, and it's a form of focal dystonia. And it can be triggered by bright lights, which is why a lot of people like to actually wear sunglasses inside and outside if they have blepharospasm. Blepharospasm can be idiopathic, meaning it just occurs by itself without Parkinson's, but it can happen to a Parkinson's patient, usually like after some years of diagnosis. Now, the epidemiology of idiopathic blepharospasm is this, but it's a little bit different with Parkinson's. I didn't get a chance to look into that, but it's usually more females than males, and the usual age of onset is 40 to 60 for idiopathic bleph. So, and then idiopathic blepharospasm can be part of this whole like craniofacial dystonia, where people will not only have blinking in their eyes, but also the oromandibular dystonia. And this is called Mage syndrome when they have both, like all things going on with face and lower face. So with the sites of injection for blepharospasm, we like to give it into the orbicularis oculi muscles and the corrugators. And for the case of the jaw clenching, we give it into the masseters and the temporalis muscles. And also another indication is if someone has tic disorder, like Tourette's, and then they have very focal tics, which is like eye blinking tics, we can give them Botox as well to help relax those muscles and open them up so that they're not blinking so much. This is just a show, this is the facial anatomy. So this is the orbicularis oculi muscles I'm talking about. And then this is the procerus muscles. And then this is the corrugator muscle. So we like to inject all over here to help relax those. It seems a little counterintuitive because you would think that when you inject, it like causes weakness, but actually what's happening is with blepharospasm, people are blinking too much, so their eyelids are overactive. When you put the toxin in, then it helps open up those eyelids because it weakens that contraction that is happening constantly. Here is a video of just people with blepharospasm.
Other times, she has sustained eyelid closure. Note that she has some brow spasm as well.
Although I don't think that these are Parkinson's patients per se, but you know, this is what happens.
In previous patients, this patient has a condition called atypical blepharospasm or apraxia of eyelid opening. This condition occurs primarily in patients with Parkinson's disease and in patients with a degenerative disorder similar to Parkinson's disease called progressive supranuclear palsy. Note that this patient does not have an increased blink rate, but rather a reduced blink rate. Most of the time, his eyes are wide open. In addition, when his eyes do close involuntarily, the closure is only partly a spasm and partly a very sustained closure that may last for 5 to 10 seconds or more. Sometimes the patient can almost immediately open his eyes. At other times, the eyes remain closed despite his efforts to open them. Most patients with atypical blepharospasm have certain tricks that they can do to get their eyes open. This patient's eyes open when he touches the corner of the right eyelid. In general, patients with apraxia of eyelid opening do not respond nearly as well to Botox injections as do patients with simple benign essential blepharospasm or Mege syndrome. This patient also has apraxia of eyelid opening. Like the first patient, his eyes are open most of the time. When they close, the closure is more gentle, with very little associated spasm. Like the first patient, he has a trick to get his eyes open. He covers them both with the palms of his hands. When he takes his hands away, the eyes are open. Because this patient has very little true spasm of his eyelids, he probably would not benefit or would benefit very little from Botox injections.
And then this next part of this video is how to prepare the Botox, which we don't have to go through. But so basically, this is the Botox vial. It's a powder inside. And then this gentleman is going to take the saline solution, which is a liquid, and pull it into the syringe. And then
sterile saline with preservative is opened. Saline is drawn up in a sterile syringe.
This is what my nurses do for me, and then I just have everything ready.
Reconstitution with saline with preservative results in a solution that is less painful during injection than solutions of Botox made up using saline without preservative. The amount of saline used depends on the concentration desired. Because the botulinum toxin molecule is very fragile, care must be taken not to damage it during reconstitution. This is best achieved by tilting the vial of Botox in such a way.
Yeah, this is kind of getting in the weeds here, but yeah, this is how you turn on. All right, and then this is what I want to show you really. what we do to inject into the eyelid muscles.
For patients with benign essential blepharospasm, we generally inject medication subcutaneously in 8 to 9 sites, 2 in the upper eyelid, 1 or 2 just behind the lateral canthus, 2 in the lower eyelid, and 3 just at or above the eyebrow.
Really, you have to have a steady hand.
Isn't that painful?
It's a painful, yeah. It's an injection around your eyelids. It could be a little scary. Yeah.
The upper eyelid injection should be placed.
Usually no anesthesia, but if we can give topical creams that are like lidocaine to help with it.
Also be given close to the eyelid margin.
And so the ophthalmologist can do this. Movement disorders trained neurologists do this.
The lower lid injections should also be placed close to the lid margin. Each injection should produce a slightly raised area.
Yeah.
The most medial brow injection should be eyelid.
I guess this is another example of another guy getting it done.
On the
Same thing.
face during the injection. Thus, if the patient's head moves during an injection, the hand will move in the same direction as the head.
Seems scary, but it's worth it to many people because then they can see for 3 months.
This video was made.
And then moving on to sialorrhea, also known as drooling. So drooling happens in Parkinson's, not because folks are making too much saliva, but because of the automatic functions are less because of the bradykinesia in Parkinson's, the slowness of movement. So just like we usually are swallowing our own saliva just automatically, and we're usually blinking pretty automatically, and our facial expression is full automatically, all people with Parkinson's can have just less robust these functions kind of in the midline. So then if they're not swallowing their saliva as much, that causes the saliva to pool in their mouth, and then they can start to drool out. Sialorrhea can be often a first symptom of Parkinson's, and it can improve with levodopa because levodopa helps with the slowness, the bradykinesia in Parkinson's. What you can do behaviorally is to just consciously make yourself swallow. So especially when folks are doing something like they're focused on a task like knitting or sewing, they can forget to swallow, and then the drool can start to pool out. So just like remind yourself to swallow. You can stimulate the saliva clearance by chewing on sugar-free hard candy or gum over the day to encourage your swallow reflex, and that keeps the saliva levels down. And then for posture, that's important. So don't tilt your head forward because then the saliva is going to pool and then come out. But just try to, this goes without saying, to put your shoulders back, put your head up high, and your chin parallel to the floor, so it's not all pooling and coming out. And that's good for generally your posture anyway. Certain medications can be used before you move on to Botox. So like levodopa helps with the drooling problem. Some people like the atropine drops under the tongue. Atropine is usually given into the eyes to kind of like, does it dilate or make the pupils smaller? I forget why. But if you prescribe it to place under the tongue, then you can reduce the production of saliva. Or you can give a patient glycopyrrolate tablets, but it has the anticholinergic side effect of causing constipation and dry mouth, which is what you're trying to achieve, and then possibly cognitive issues. So it's not the best idea for the glycopyrrolate. And then, of course, we're talking about botulinum toxin. So these are the sites. The parotid gland sits right over here above the masseter muscle. So it's very superficial, and we can give it in 3 or 4 sites over here. And then the other gland that makes saliva is the submandibular gland over here, underneath the chin here. So we often give it in both glands. There is, when you inject close to the muscles of swallowing, there is a risk of it migrating and causing swallowing issues. Of course, we try our best not to do that. But the good thing about Botox and the bad thing about Botox is that it wears off. So if you have an unwanted side effect, it will wear off. But then if you have a good effect, you have to come back. They're actually, I think they've been talking about this for 1 or 2 years now, that they're trying to develop a botulinum toxin that lasts more than 3 months, that's supposed to last 6 months. And this is good for people who just need maintenance and have a good pattern and units that they know works for their certain postures. That's my last slide on this botulinum toxin topic, but I just want to give you a plug for our symposium that's coming up. We have a yearly symposium. It's at the Overland Park Marriott. Last year, I think it was like 900 or 1,000 people registered and attended. So if you have the time, come on by and hear about what we have to say. And always a really good part of it is when Dr. Pawa and his buddy Stuart Isaacson comes by and does their Q&A answering.
Do you know the date?
Oh, it is August 15th. Yes. Yes. There you go. So I'll probably see many of you there. So with that, I will end this part of my talk. See if you have questions about any of this.
I have
Yes.
a question. Okay, so, 2 things. If you're getting the Botox for the eyes, does any of that increase flat affect? Although it sounded like maybe not, but then also if you get the drooling and the swallows, then so you get the injections for the drooling, but would it enhance or impact swallowing if someone has drool?
Yeah, that's always tricky. I mean, the muscles of swallowing are in the pharynx, and they're deeper than where we would be injecting in the submandibular gland and the parotid gland. And so some people have trouble negotiating their saliva, and then they're actually choking on their own saliva, and that's causing aspiration. And so in the case of giving the Botox for that reason, it's helpful. But for swallowing liquids and solid foods, I mean, I think that's a separate thing than the saliva problem.
So it wouldn't impact if they already have problems with swallowing hard like food, and then they had the botulism for.
We try our best not to hit any of the pharyngeal muscles here that control swallowing. We want to stay in the submandibular gland. If there's any concern for that, we would just not go there, and we only do the parotid gland. Although the parotid glands, I read, so when it's stimulated, it causes 100% of saliva reduction when it's stimulated, meaning when you're actively eating food and you have a smell of food, and then you have all the kind of your nervous system is like alert that food is happening. Whereas when it's unstimulated, in an unstimulated state, and you're just kind of idle, maybe you're like doing a task, then the submandibular gland produces most of the saliva in that case. So you want to improve. Yeah, and that's often what people are concerned about when they are talking about their drooling, because it happens in the worst times, not just when they're eating. Yeah.
But usually people who over salivate have too much saliva that they're dealing with, the drooling.
Well, it's not so much in Parkinson's that they have too much saliva. It's just that they're not negotiating, they're not swallowing it as automatically. Just like they're not blinking as automatically. They're just not doing it at a regular rates, because it's just kind of something that we all automatically do, but the Parkinson's patients don't do it as much, and it pools.
How do you treat just the facial tips around the mouth or in the nose? I mean, that's something that still has developed in it. I didn't know that there's anything.
Well, if it's
change the medication or the level.
Yeah, if it's as a result of dyskinesia when he's on and the medications are working and causing excess movements, if it's not bothersome, then we don't have to do anything about it. We like to see a little dyskinesias. It bothers the partners more than it bothers the patients. Usually that goes with any dyskinesia, but most of the time patients who are having the dyskinesias, they don't even notice. They're not aware of it, and it doesn't bother them. And it means that they're in a state where they're more fluid and less stiff, and they would prefer to be dyskinetic than bradykinetic. So we don't have to treat every tremor or dyskinetic movement. Yes.
Are there additional risks for patients who have had Botox for cosmetic or even some of these other procedures from just the cumulative effect or lessening of the impact?
Yeah, it was so before in like the 90s and early 2000s, before I think the techniques for purifying the toxin was really like made very clear and really purified. There was possible contaminants and things, and then people would say, "Oh, it's weren't like it doesn't work for me anymore because like I've built a resistance or like antibodies to it in my own body, where it's ineffective for them." So that was the case years and decades ago, but now we have developed such a good technique to purify the toxins that it should work every time. And if you're not sure if it's working or not, one of my mentors told me that like what you can do is put like a little bit in the forehead muscle, and then while you're also doing wherever else you're doing, and then if they can't raise their eyebrow up, then that it means it's working. But if we're worried about one certain toxin not losing its effect for whatever reason, which is very rare but can happen, then we go to the other three toxins and see if they get better on those. So there's options.
Either way, they need to give it a 8 months history to know what they may have had before.
Oh, sure. Yeah. So if someone has had cosmetic Botox and they come in to me, I mean, it's still going to work. It's going to work.
Do you have people get sick, like is botulism or anything from that, or is it protected enough now that people get sick?
Well, so getting sick would mean if it's injected into your vessels and it goes all around your body, and it can affect the muscles that are of breathing and of swallowing, which rarely on the label they will list that death is one of the possible complications of Botox. But right, but it doesn't. It generally does not happen. Yeah. Although for the so with cervical dystonia, the cervicotalamassoid muscle, which is this strap muscle right here, it's very also close to the pharyngeal muscles of swallowing. And so with that technique and that muscle, you want to stay in the upper 1/3 of the muscle and not the lower 2/3, so that you avoid any of the swallowing muscles. And you want to point it upwards, and you do want to use your EMG machine or whatever guidance technique you have, so you know that you're definitely in the correct spot.
So just make sure you have somebody really good.
Yeah.
So you don't get.
Yeah. Although we all have to learn, so if you have a fellow with you, they're going to be supervised, and we all learn somehow. Mm-hmm. Anything else? Yeah.
So did you say, is it dyskinesia or dystonia, where some people either, I've seen it with one leg swing in front, or even sometimes I've seen where they almost cross it back as they walk. Is that considered part of, like with more advanced parts?
Right.
That
right. It can be hard to tell because, so dystonia is usually thought to be just more postured and fixed of the pattern, whereas the dyskinesia is more wiggling and writhing. So you can kind of tell that way.
But with the botulism, and it's more as a term, so it would be a dyskinesia. Like if it's coming around either forward or behind, is that something that the botulism?
Potentially.
Potentially.
Yeah.
Uh-huh.
Yeah, potentially. Yeah. Uh-huh. Uh-huh.
if you think about let's talk about this first, then we can do this, and then we can do this, and then this, or do you not have a machine? There's some kind of
Yeah. So it depends on the age of the patients. If they're in their 40s or 50s and they can tolerate these medications, and I try to give them these to see if it helps with their dystonic posturing, and then also while offering Botox, and then thinking about whether, in the next visit, if they, keep talking about it, if they want the Botox. If the patients already are complaining of constipation and they're already complaining of cognitive problems, and I do not want to give these medications because it's going to worsen that. So like you said, it's really individualized. Um, I'll say that often, I mean, with these medications are more geared for people with more generalized idiopathic dystonia, whereas for Parkinson's disease patients, it's better off to just go jump straight to the toxin because it's just so focal, and where you inject it is where it stays, and it doesn't cause the systemic side effects. Yes.
Is this something you have to ask for from your specialist, or does it just logically happen? They see what a symptom is and they say, oh, we should do this.
Yeah, it depends on how the awareness of the neurologists, and if they're asking the questions, and if they're seeing on the exam that the dystonic postures are happening. But this is why we're giving these talks, so people are more aware and they can ask for it and access it themselves. Yes.
Recently,
For drooling.
for any not FDA approved.
Oh, it is FDA approved. So it is FDA approved. At least Botox is FDA approved for these indications, but actually not drilling. And these are the years that it became FDA approved. Except for Botox, drilling is Xeomin and MyoBlock only for whatever. I don't know why. It's just a lot of red tape, bureaucratic nonsense. Yes.
Taken nuts with migraine headaches.
Ah.
That's surprising.
No, not at all. Very normal, very effective. Yeah, FDA approved since 2010 to treat chronic migraines, which is classified as 15 or more headaches per month, and refractory to medications, which the medications themselves can cause all sorts of side effects. And then the protocol for migraine pattern is pretty simple. There's 31 injection sites around the procerus, corrugators, the forehead, the temporalis, and then in the back over here. And it's thought to kind of just relax those muscles that might be tensing up and generating that headache. And also there's some thought that it lessens the CGRP that's happening. This is a newer, this is after I finished my residency in 2017, that the new migraine treatments include the CGRP compounds, which blocks CGRP, which is this compound that we now know causes a headache. Every 3 months. Patients would prefer to having those and then not. Yeah. 31 sites, yeah. It's bing bam boom though. It's really quick. Well, it's 31 across. So the forehead, the temples, there's four here, 4 here. That's already 8. 3 here, 3 here, 3 here, 3 here. That's already what, 12? So 8 plus, and then there's some here, and then the forehead.
So do they do everything?
Yeah, it's just part of it's called the preempt protocol, where that's just what was developed to treat migraines. But some headache neurologists individualize it too. So if someone's having more of a one-sided headache, they can do more on the one side. Or if they're also clenching their teeth for their headache, they can do it into their masseter muscle. So it can be changed.
All right. Well, thank you so much,
You're
Dr.
welcome.
Lee.